Good afternoon, and welcome to Committees on Health, jointly with Hospitals and Land Use. At this time, we please ask to place phones on vibrate or silent. Thank you for your cooperation. Chairs, we are ready to begin.
Thank you. I now call this hearing to order. Good afternoon. I am Councilmember Lynn Schulman, Chair of the New York City Council Committee on Health. I want to thank all of you for joining us at today's joint hearing with the Committee on Hospitals, chaired by Councilmember Narcisse, and the Committee on Land Use, chaired by Councilmember Salamanca. We are also joined today by Councilmembers Brooks, Powers, Lewis, Hudson, Kagan, Rivera, Velasquez, and Mealy. Did I miss anybody? No. Today we are here to, and Baccia, I'm sorry. Today we are here to talk about a very important issue, the glaring inequities in access to health care within our city. COVID-19 has been the biggest public health crisis of our lifetime. The virus exposed the deepest vulnerabilities of our community. At the height of the pandemic, there were clear disparities in resources, capacity stress, and quality of care between healthcare providers and hospitals across the city. For that reason, the purpose of today's hearing is to look back at the issues that arose as the city battled COVID-19 so that we are better equipped to handle future emergencies and prevent the needless loss of life. As we all know, the situation in the city's hospitals was dire in late March and early April of 2020. The city experienced an increase of around 1,600 new hospitalizations per day, while hospitals struggled with limited numbers of ventilators, access to personal protective equipment, and staffing shortages. To increase the number of beds, all general hospitals, surgery centers, surgery practices, and diagnostic and treatment centers were required through executive order to cancel elective surgeries and procedures. As a result, access to non-COVID related health care was greatly impacted. Nearly half of adults reported delaying or avoiding medical care, including urgent or emergency care and routine care. According to the American Cancer Society's Cancer Action Network, nearly 1 in 4 cancer patients reported delays in their care due to the pandemic, including access to in-person appointments, imaging, surgery, and other services. This is something I know firsthand. When I was diagnosed with breast cancer during my 2021 campaign, I became an advocate for other breast cancer patients who couldn't get their tumors removed as a result of these restrictions. The pandemic also further exposed the stark disparities in access to health care for communities who are most at risk. In the summer of 2020, of the 10 zip codes with the highest death rates in the city, 8 had predominantly Black and Hispanic populations. Data showed that residents of the Bronx, Queens, and Brooklyn had higher rates of hospitalizations and death than both Manhattan and Staten Island. It comes as no surprise then that the difference in hospital capacity between the boroughs is drastic. While Manhattan has approximately 5 hospital beds for every 1,000 residents, the Bronx, Brooklyn, and Queens each have less than half that number available, and I just want to make mention that Queens is the lowest of those. I believe that health care is a human right. All New Yorkers should have access to affordable and equitable health care. The issue of hospital capacity and disparate resources predates the emergence of COVID-19. Over the past 2 decades, Queens and other boroughs have lost an alarming amount of hospitals and other resources. From 2003 to 2014, the number of hospitals in New York City dropped by more than 20%. The pandemic has only underscored the need for improved local access to quality care within our communities. New Yorkers can't afford to not have emergency care locally available when we need it most. I have dedicated my personal and professional life to healthcare advocacy. As someone who has had first-hand experience working in the healthcare field, I believe these issues must be addressed to ensure that New Yorkers' lives aren't put in jeopardy because of a failing system. Not only are we in desperate need of additional hospital capacity, but we need a system that can provide affordable, preventive, and primary care and have the ability to respond to public health emergencies. We cannot be left with another fatal shortage of hospital capacity in the midst of a crisis. No matter what zip code you live in, you should be able to have access to quality, affordable health care. This is literally a matter of life and death. I want to conclude by thanking the committee staff for their work on this hearing. Committee councils Habani Ahuja and Sarah Sucha, and policy analyst Manor Butt, as well as my amazing team, including Seth Urbender, my Deputy Chief of Staff, legislative staff at Kevin McAleer, and my communications director, Javier Figueroa. I will now turn the mic over to my colleague and chair of the Hospitals Committee, Councilmember Mercedes Narcisse.
Thank you, Chair Schulman. Good afternoon, everyone. I'm Councilmember Mercedes Narcisse from the beautiful 46th District, Chair of the Committee on Hospitals. Thank you for joining this very important hearing. The COVID-19 pandemic has shown us the vulnerabilities and the inconsistencies in our public healthcare system. In the New York City alone, about 42,000 people have lost their lives to this virus. Data shows that the top 10 New York City zip codes with the greatest death toll predominantly house Black and Hispanic communities, reflecting the systemic healthcare disparities still plaguing our city. The Health and Hospital Network, the backbone of New York City public health system, serve the most vulnerable members of our society, including low-income families, homeless individuals, and undocumented individuals, free of cost. H&H provides over 58% of the uninsured healthcare, addressing the needs of the city's most marginalized members while being severely underfunded by the state. During the early days of COVID-19, the hospitalization rates surged up to 12,000 people per day, creating a great bed shortage along with a lack of necessary healthcare professionals, PPEs, and ventilators. All things crucial to serving our patients in middle of a public health emergency. However, these conditions were not just the result of an unprecedented pandemic. It was the outcome of years of neglect of our public healthcare system. I understand some issues are beyond our control, like this morning. I apologize. But for those we can control, let's do our very best. H&H is funded by the shrinking state and the city grants and tax subsidies and the Medicare reimbursement, known for their low rates and slow repayments. As a former nurse at Elmhurst Hospital Emergency and Trauma Center, one of the 11 H&H hospitals, I have personally experienced the shortfalls of funding and the lack of resources which affect a hospital's ability to serve its patients. Hospitals are chronically understaffed and overcrowded, working beyond their capacity. During COVID-19, the hospital's patient-to-workers ratio, which should ideally remain at 4-to-1 ratio, jumped in some hospitals as high as 23-to-1. Thankfully, COVID-19 hospitalizations are now down, but we must learn from our mistakes. We must make investments in primary and preventive care in our communities, invest in FQHCs and community clinics, and address the root causes of chronic health conditions and health disparities, which we were made disturbingly clear during the pandemic. We must make investment in Black and Brown communities to improve healthcare outcomes. And we must support our public and safety net hospitals so they have the resources they need to do their jobs. I look forward to hearing from the administration today about how we can work towards a more equitable healthcare system for New Yorkers. I want to conclude by thanking the committee staff for their work on this issue. Before I do that, I want to remind you all today, make it 46th District have no community health centers, no hospitals. And the hospitals that serve us are way underfunded. So I want to conclude by thanking all of you and the committee staff for their work on this issue. Committee counsel, Habani Hahuja, and policy analyst, Mono Butt, as well as my wonderful Chief of Staff, Syed Joseph, and my Deputy Chief of Staff, Frank Shea. Thank you. I will turn it over to Chair Salamanca to give his opening statement. Thank you.
Thank you, Madam Chair. Good afternoon. I am Councilman Madafar Salamanca. I'm the chair of the Committee on Land Use. As my colleagues have described, the peak of COVID-19 pandemic stressed the capacity and capabilities of New York City's hospitals and healthcare system as never before. This unprecedented stress on the system called attention to issues of healthcare capacity, access, equity that are no longer overdue for more comprehensive approach. New data accumulates daily showing ongoing several racial and social economic disparities in COVID-19 mortality rates and a grave disparity in care received at different hospitals across the city. Communities like my district in the South Bronx have suffered far greater health impacts from the pandemic than the wealthier parts of the city. These impacts result not only from the quality and availability of local hospitals, but also from lack of access to primary care and from long-term inequalities and access to a healthy environment and economic opportunity. This is why I'm here today in my capacity as Land Use Chair. New York needs to move forward a more holistic, coordinated approach to ensure the development of an equitable 21st century healthcare delivery system. Our city and state agencies must work together to expand access to quality primary care, ensure a baseline standard of access to quality hospitals, and use all available tools to understand and address the social, environmental, and economic factors that are at the root of persistent health inequalities. Planning for our public health must work in tandem with planning for housing, open space, economic development, and our social infrastructure. I look forward to continuing to work with the Health and Hospitals Committee on these issues, and I thank the staff of all three committees for their ongoing work. Thank you.
Thank you, Chair Salamanca. Before we move forward, I want to acknowledge that we've been joined by Council Members Yeager and Joseph. I want to welcome the admin today. We're joined by Rishi Sood, Executive Director of Healthcare Access and Policy for the Department of Health and Mental Hygiene, Dr. Andrew Wallach, Ambulatory Care Chief Medical Officer for New York City Health and Hospitals, David Silvestri, Assistant Vice President for Emergency Management, and Manuel Saez, Senior Vice President of Facilities at Health and Hospitals. Please proceed with your testimony. Oh, okay, sorry. No. You have to get, sorry, the council will give the oath.
Will you please raise your right hand? Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to council member questions? You may begin.
Turn this on? Okay. Good afternoon, chairpersons Schulman, Narcisse, Salamanca, and members of the Committees on Health, Hospitals, and Land Use. I am Dr. Andrew Wallach, the Ambulatory Care Chief Medical Officer at New York City Health and Hospitals. Importantly, I'm also practicing primary care physician at Health and Hospitals Bellevue. I am joined today by my colleagues from H&H, Dr. Dave Silvestri, Assistant Vice President of Emergency Management and a practicing emergency medicine physician at Health and Hospitals Lincoln, and Dr. Manny Saez, our Senior Assistant Vice President of Facilities. Thank you for the opportunity to testify regarding the work Health and Hospital does to promote access to health care for all New Yorkers and to ensure its preparedness for emergencies. While Health and Hospitals is only one component of a much larger healthcare delivery system in our great city, we are very proud of what we do. Health and Hospitals is indeed the largest municipal healthcare system in the United States. Our mission is to deliver high-quality healthcare services with compassion, dignity, and respect for all, regardless of insurance status or the ability to pay. We provide essential inpatient, outpatient, and home-based services to more than 1 million New Yorkers every year in more than 70 locations across all 5 boroughs in New York City. More than 60% of our patients identify as either Black, African American, Hispanic, Latinx, or Asian American, Pacific Islander. More than 70% of our patients are insured by Medicaid or have no insurance, including nearly 400,000 uninsured New Yorkers who otherwise would not have access to care. Health and Hospitals offers high quality and affordable healthcare services at our 11 acute sites, 5 post-acute skilled nursing facilities, and through our federally qualified health centers, or FQHCs, known as Gotham Health. Gotham Health has over 50 community health centers throughout all 5 boroughs, allowing us to address the primary care needs of families and individuals in their own neighborhoods. At both our hospital-based primary care practices and the Gotham Health Centers, we provide routine checkups, preventative health screenings, and immunizations for both children and adults. We perform chronic disease management, including for asthma, heart care, and diabetes. We offer adolescent health services, behavioral health services, diagnostic imaging services, women's health and maternity care services, well baby care and pediatric services, senior care, and geriatric specialties. We also are helping implement lifestyle changes and other wellness goals of our patients. Health and Hospitals offers free language service 24 hours a day, 7 days a week, 365 days a year, in over 200 languages and dialects. We translate key patient documents such as consent forms and patient education materials into the top languages spoken by limited English proficient New Yorkers, who represent an estimated 30% of our patients. In addition to our extensive physical footprint across New York City, I am also incredibly proud of our new telehealth and mobile services, which expand access to care and allow health and hospital patients to receive their care where and how they need it. For telehealth, we have several options, such as telephone appointments, video visits, and an online patient portal for patients to connect with our healthcare providers without coming into the doctor's office or hospital, all accessible via our MyChart system, part of our electronic medical record. For non-emergency urgent care services, we offer Virtual Express Care. Virtual Express Care has launched in 2020 to ensure convenient one-click access for patients seeking urgent care services to the most appropriate level of care where they were safest during the first wave of COVID-19 in their home. Virtual Express Care is available 24/7 and allows patients to receive virtual care from a Health and Hospitals provider for common physical, mental, emotional, and behavioral health issues. We provide this service in over 200 languages, including American Sign Language, with in-screen interpretation services. Virtual Express Care has become a nationally recognized leader for its COVID-19 treatment model that helps patients access treatment via telehealth and offering home delivery for antiviral medications and same or next day treatment with monoclonal antibodies. Additionally, this summer we received funding to launch and integrate a new telehealth behavioral service into Virtual Express Care, and to create a tailored version of the new telebehavioral healthcare service for New Yorkers experiencing homelessness. We are also bringing care directly to New Yorkers. For New Yorkers experiencing homelessness, the Street Health Outreach and Wellness, or SHOW, mobile units engage individuals where they are and provide vital health and social services. These SHOW units have provided COVID-19 testing and vaccines, behavioral health care, and a host of other harm reduction and social services to well over 100,000 New Yorkers. In addition, our mobile Test to Treat program offers COVID-19 testing and Paxlovid distribution to thousands of New Yorkers via 30 mobile vans. To ensure deployments are reaching New Yorkers most in need, 75% of our mobile test-to-treat locations have been established in neighborhoods the city's Task Force on Racial Inclusion and Equity, TREE, determined were hardest hit by the COVID-19 pandemic. Hospitals play an essential role in planning for and responding to the needs of New Yorkers during any citywide emergency. Health and Hospitals has a history of preparing for, responding to, and recovering from a myriad of emergency events, including pandemics. While Health and Hospitals has been activated in response to the COVID-19 pandemic, we have had to currently respond to multiple other emergencies, including coastal storms, winter storms, mass transit shutdown, extreme heat, and most recently, the monkeypox virus outbreak. Health and Hospitals has maintained and even expanded operations throughout each emergency event and provided continuity of care to our patients and the communities we serve. Health and Hospitals uses an incident command system, ICS, to manage all disasters, emergencies, and other incidents. The ICS is a national best practice for coordinating emergency response and allows for communication, coordination, and collaboration with other agencies. A central office incident management team embedded within the system's ICS is responsible for coordinating emergency response across the health system. Once Health and Hospital activates the ICS, internal and external notifications are made while information is gathered for situational awareness. Staff are assigned to their incident command roles, briefings are held providing the latest intelligence, and an incident action plan is developed for the first operational period. This process repeats for each operational period throughout the activation. Similarly, for preparation and planning of an emergency, Health and Hospitals also utilizes the ICS. Trainings and exercises take place regularly where each facility tests components of the emergency operations plan to ensure operations and communication chains run smoothly. In addition to its robust procedures to address an emergency as it unfolds, Health and Hospitals takes great efforts to ensure its preparedness well before the disaster strikes. To ensure the safety of its patients and staff, Health and Hospitals has extensive plans in place in the event of weather, public health, or other catastrophic emergencies. Our emergency operations and response plans are developed to address all hazards, with specific incident response annexes and guides for high probability and high impact events, which include coastal storms, extreme temperatures, and winter and summer weather events. Each of our sites is required to conduct training and exercises to test and evaluate their plans. Planned exercises and actual response activations are reviewed to identify gaps and areas for improvement. Importantly, we do not work alone. Health and Hospitals works closely with the Mayor's Office and the New York City Emergency Management in all phases of emergency management, including planning, mitigation, response, recovery, training, and exercises. Each year, Health and Hospital participates in exercises with other agencies and are led by NYSEM. While the intent of these exercises is to test plans and identify gaps, real-life activations also serve this purpose and allow for real-time identification of gaps and resolution of the issues. In addition, Health and Hospitals partners with other hospital systems in New York City through the Greater New York Hospital Association to prepare for emergency events. We are always striving to better serve our patients and make our system even stronger and better prepared for the next emergency. Health and Hospitals is committed to enhancing the resiliency of its facilities in order to mitigate future disasters, plan for future emergencies, and shore up our aging infrastructure. We're learning and building resiliency from COVID-19, shoring up facilities, increasing patient capacity, safeguarding long-term COVID-19 services, and supporting our staff. We have also learned and rebuilt after major hurricanes. Sites that incurred flood damage after Hurricane Sandy made major improvement measures, including moving critical infrastructure to higher floors, flood protection for our facilities, flood-resistant infrastructure, investing in generators, electrical panels, HVAC systems, and other capital projects. In May, Health and Hospitals and the New York City Economic Development Corporation broke ground on a new flood protection system at New York City Health and Hospitals Metropolitan in East Harlem. In October, Health and Hospitals will open the Ruth Bader Ginsburg Hospital at New York City Health and Hospitals South Brooklyn Health Campus. This will feature a new concrete flood wall and flood-resilient infrastructure for power, heating, cooling, and water systems. Over the next 10 years, Health and Hospitals has significant infrastructure needs, however, including IT, equipment, and capital improvements. This includes work specific to the COVID-19 response, green energy upgrades across the system, and work to improve the patient experience, such as individual patient rooms, improved behavioral health settings, and renovated operating rooms and emergency departments. Infrastructure improvements are especially important to Health and Hospitals as a safety net provider. Our infrastructure is 17 years old on average, compared to an average of 9 years for other New York City hospitals. We have made significant investments to modernize our facilities, and we are grateful to the council, the mayor, and borough presidents, as well as our federal delegation for their crucial funding support. Hospital and healthcare infrastructure should be considered equally critical as roads and bridges, and we continue to engage on this topic at the city, state, and federal levels. In closing, it is the mission of Health and Hospitals to deliver high-quality healthcare services with compassion, dignity, and respect to all, without exception. Every day, we work towards that mission and strive to continuously improve our services and stay ready for the next challenge. Thank you to the committees for the opportunity to testify and for your continued support of Health and Hospitals. I look forward to our continued partnership and answering any of your questions. Thank you.
Thank you. I just want to advise that everybody has about 5 minutes for testimony. If you could summarize, because we have the testimony in writing, which we are going to take back with us, that would be great. Thank you.
Good afternoon, Chairs Schulman, Narcisse, and Salamanca, and members of the committees. I am Rishi Sood, Executive Director of Healthcare Access and Policy at the New York City Department of Health and Mental Hygiene. Thank you for the opportunity to testify today. The Health Department believes access to quality healthcare should be available to all New Yorkers. In the past 2.5 years, we have seen and experienced how important and essential access to healthcare is. Yet social, economic, and geographic factors can often be barriers to receiving health services, especially for marginalized populations. Lack of access to healthcare is both a public policy issue and a moral one. We work together with other city agencies such as Health and Hospitals, community-based organizations, and community healthcare providers to identify and respond to the barriers that prevent access to healthcare to ensure that all New Yorkers can receive the care that they need. Over the last 2.5 years, the city has worked tirelessly to ensure equitable access to care was provided for all New Yorkers during the COVID-19 pandemic. From standing up a massive vaccine infrastructure to supporting the existing healthcare system and ensuring distribution of available treatments. The city pursued a broad effort to address health disparities and serve communities hardest hit by COVID-19, focusing on the 33 Task Force on Racial Inclusion and Equity, or TREE, neighborhoods. We broke down language access barriers by bringing translators and translated materials to vaccine sites and partnering with community-based organizations to deliver critical health information to their communities in the languages that they speak. We met people where they were by deploying mobile vaccines through tents, vans, and buses to locations across the city where people live, work, dine, commute, learn, play, and we even brought them into their homes. And more recently, the city increased capacity to ensure that New Yorkers have access to the medication needed to treat COVID-19 as soon as they test positive through telehealth services, same-day delivery, and treatment vans. The collaboration between public and private partners that exists in our COVID-19 response extends to the Health Department's work every day to address the social and environmental factors that impact health. Specific to our work to address healthcare access, we engage with community health providers to bolster their capacity to serve their neighborhoods. Our support for these providers helps to identify and address residents' healthcare needs and reduce their health risk factors for both chronic and infectious diseases, to provide support for telemedicine, and to ensure that providers receive adequate PPE to reduce their own risks during public health emergencies. Our engagement with the community involves collaborating with community partners to identify issues that lead to poor health outcomes, to create response strategies, increase awareness of health information on infectious and chronic diseases, and ensure that residents receive resources and services that they need. We work with trusted partners in the community, and this is an essential part of the health department's work, dispelling misinformation and promoting positive health behaviors. In addition, the health department works closely with other agencies, including the Mayor's Office of Immigrant Affairs, Health and Hospitals, and the Department of Homeless Services, to provide services to immigrant populations. We work collaboratively to provide psychological first aid, emotional support services, health insurance enrollment, and to connect individuals and families to primary care appointments. We work closely with the Community Healthcare Association of New York State, individual community health centers and networks, and primary care providers and stakeholders across the city to ensure access to primary care services and continuity of care for all New Yorkers, particularly those who are uninsured or low income. And we continue to identify ways to improve coordination of the healthcare safety net during complex public health crises such as monkeypox and COVID-19, as well as on an ongoing basis. New York City's healthcare safety net is always in need of more resources, but it is strong, healthy, responsive, and available to all New Yorkers, regardless of insurance or immigration status. We recognize that health insurance provides a vital pathway to care and financial protection, particularly for more specialized care. As such, we work through our own Office of Health Insurance Services to enroll New Yorkers into coverage through the state marketplace and to provide enrollment assistance with both paper and web-based applications and renewals. Our staff are designated Certified Application Counselors, or CACs, trained to provide education, outreach, and enrollment services from our health centers across the city. CACs help all New Yorkers with a focus on people who are lower income, Black, Latino, and immigrant communities, and those who are medically vulnerable. In collaboration with other city agencies, we assist the older adult 65-plus population and certified blind and certified disabled populations in New York City through education, outreach, and enrollment assistance for public health insurance. Additionally, we assist with applying for the Supplemental Nutrition Assistance, or SNAP, program and refer individuals to other social service organizations as needed. It is important to note that regulation of healthcare facilities, including hospitals, is conducted by the state, specifically the New York State Department of Health. Among other responsibilities, the state's Public Health and Health Planning Council receives and makes decisions on certificate of need applications submitted by hospitals, home care agencies, and hospice facilities when they are looking to establish new facilities, transfer ownership, or make substantial changes. In the face of this landscape, the Health Department utilizes a multifaceted approach to support New Yorkers in accessing quality health care, and we will continue to provide equity and access to ensure New Yorkers are getting the services and support that they need. Thank you again to the chairs for holding this hearing today. I'm happy to answer any questions.
Is there more testimony? Okay. All right, so what we're going to do is, some ground rules. One is, I'm going to actually, I would be the first to ask questions, but my colleague, Brooks Powers, has a childcare issue, so she's going to ask some questions. Then I'm going to do it, and then Chair Narcisse, Chair Salamanca. Also, we're going to, because there's so many members here today, we're going to limit members to 3 minutes of questions, and if we can get a second go-round, we will. So, Councilmember Brooks Powers.
Thank you so much, Chair, and good afternoon, everyone. I'd like to express my appreciation for the chairs for convening today's hearing, Council members Shulman, Narcisse, and Salamanca, and our committee staff for facilitating. Like many communities across the city, my district and Rockaway in particular suffer from disproportionately poor access to quality care. Following the closure of Peninsula Hospital in Edgemere over a decade ago, Rockaway residents face dangerously low travel times to the nearest facility, which right now is all the way in downtown Jamaica. It's about time we bring quality health care back to the peninsula, which is why I've been working hard with dozens of community partners to establish a health access task force to identify the best opportunities to close these gaps and keep Rockaway residents safe. I look forward to engaging with health and hospitals and other healthcare providers across the city to identify opportunities to increase access. In light of these pressing issues that are facing communities across all 5 boroughs, I'd like to ask a few questions. First, I'd like to know, how do the agencies present today, coordinate in identifying the best locations for new health care facilities. For instance, is there a set of metrics DCP can provide our health agencies in terms of targeting communities most in need?
Great, thank you, Council Member, for that question. I just will remind the Council that indeed New York City Health and Hospitals does have a very extensive footprint, right, in clinical spaces with over 70 locations throughout our 5 boroughs. In addition, we're very proud, as I mentioned, of the ability for patients to receive care through our telehealth services for both primary care and for our virtual express care services. That said, to your point, we continue to assess the community need, and I think that's made evident by the addition of our 3 recent centers of excellence, all in neighborhoods that were underserved as part of the COVID-19 response, as well as our commitment in conjunction with our partners at EDC to build a new clinic in the Rockaways. We understand the importance of having these healthcare services in our communities, and again, want to emphasize that at H&H, our goal is to provide this care to all New Yorkers.
I'm sorry, so what are the, is there a set of metrics that you all look at to be able to provide these health agencies? And if so, what are they?
Yeah, so as a public safety net hospital, we again committed to using our resources for our patients here in the city. There is a process where we at New York City Health and Hospitals, as well as other hospitals in our city, as well as across the state, need to establish new services. They go through a process called this New York State Certificate of Need in order to meet that eligibility. And I'm going to ask my colleague, Dr. Manny Saez, to see if you want to add anything to that of what the process is.
Thank you, Dr. Wallach. Yeah, when health and hospitals and other health care facilities across the state seek to establish new services or construct or renovate new or existing facilities, we acquire a certificate of need that we work very closely with the New York State Department of Health. Some of those considerations include the community needs, financial feasibility, architecture and engineering standards, current compliance, and assessment of the applicant's organizational structure. It is a very lengthy process, but that is a process we follow along with New York State.
And what's the best way to be able to start a process if a community would like to have a new health facility, in particular a hospital, a trauma hospital in their community? How would you best, I guess, suggest to initiate that process?
You want to comment on that?
Well, it is doing the continuing assessment of these community needs, making sure that we can provide services to the community, that we have financial stability in the community, and more importantly, that the distribution of services is equal and equitable for all of our New Yorkers. So there are specific metrics that are considered, but for the purposes here, the taking through the CON process is the primary avenue for advocating for a new facility.
And just my last question, if that's okay. Just one last question. I just want to say, looking at the information we were provided, Queens has the most hospitals that's been closed across the city, with only 1.8 beds per 1,000 residents, which is a significant disparity. Which communities have the agency started to prioritize as most in need of better access? And I understand you have the Gotham centers that are coming, but I'm talking about actual hospitals that can handle trauma-related care. Thank you, chairs.
Yeah, thank you, Councilmember Brooks Powers. Again, I can't speak to the closures of the private hospitals, but again, we are committed to providing care, including emergency care, as you said, and trauma care to New Yorkers. Within the borough of Queens, we do have 2 acute sites, Elmhurst and Queens Hospital, as well as 8 Gotham sites that are part of New York City Health and Hospitals. Again, with regard to creating a new acute hospital, I would defer to my colleague from the Health Department to begin what that would look like as far as a process.
All right, thank you, and I'm sure we're going to revisit this some more. And we're going to go a little bit out of order. My colleague, Chair Salamanca, needs to leave, so he's going to ask questions before me and my colleague Narcisse.
Thank you, Chair. I promise I'll stay within my time. Thank you, Commissioners, for attending today's hearing. My question is, in the City Council in land use, we do many rezonings. In my district alone, in the time that I've been in the council, I've approved close to 7,000 units of 100% affordable housing. But yet, I'm not getting new services. I'm not getting more ambulances. I'm not getting an increase in the fire department, the police department, my food pantries. What communication does HHC have with city planning when we're building new housing throughout the city of New York to ensure that we're meeting the needs of the communities?
Yeah, thank you for that question, Chair. I would say one of our biggest strengths, quite honestly, are our community advisory boards that we have affiliated within all 5 boroughs associated with our facilities. These are very much a robust group of individuals who advocate on behalf of their communities, and that information is fed directly back to us. In addition, we formally do annual community advisory assessments in each of the communities where we work, and we respond based on that information that we gain from the assessments, and that helps with our strategic planning.
Okay, so you have an assessment. What action is done? You're not building new hospitals. Are you building new clinics? What exactly are you doing with this assessment?
Yeah, so great point. So most of our assessments are about the clinical needs of individuals in those communities. So for example, in the Bronx, where there are what we call food deserts, right? We are implementing a lifestyle medicine program, which helps with the delivery of fresh fruits and vegetables to individuals. We continue to advocate with the health department in order to get additional businesses and groceries to open. But with regard to your question about building new hospitals, again, I would say I can't comment on the ability of the closures of privates or beginning a process. I would defer to the state health department and to the city health department here.
I'll move on to my next question. Access to quality health care is one issue, but access to quality health care is a multifaceted issue. Since 2019, I've allocated over $7 million, myself alone, to Lincoln Hospital for a new x-ray suite, a nurse call bell, a tumor detention system, and an ultrasound and neonatal equipment, amongst other things. But despite that, Lincoln Hospital still needs millions and millions of dollars in capital needs. What is HHC doing, Health and Hospital, doing to ensure that our public hospitals that are already stretching the dollar thin have the resources needed to provide quality health care in a post-pandemic world?
Yeah, first and foremost, Chair Salamanca, I want to thank you for your personal commitment to H&H. Those dollars that you have committed to Lincoln have been very much appreciated, and we thank you for your ongoing advocacy for that facility. As I mentioned, as part of the public health system here in New York City, our infrastructure is old, certainly compared to the private facilities here in the city. And so I will ask my colleague, Dr. Manny Saez, if you want to make additional comments specific to the chair's question about how we're able to kind of move forward and what we're going to do.
Thank you, Dr. Wallach, and thank you, Councilman. And again, I echo the support that we have received at Lincoln Hospital, very much needed in that south area of the Bronx. We've been working towards providing capital submission improvements to structure and restructure a lot of our ambulatory care suites, and working amongst other services inside of the hospitals to help make those improvements.
Okay. All right. I promise I'll stay within my time. Thank you, Madam Chair, for allowing me to speak. Yes.
All right, thank you very much. I just, before I begin, I want to acknowledge we've been joined by Council Members Feliz, Borelli, Moya, Ariola, and Krishnan. Couple things. One is, over the past 20 years, 10 hospitals have been closed in Queens, which was why the pandemic, Queens was the epicenter of the epicenter, particularly Elmhurst Hospital, which I know you're familiar with. So my first question is, do you think there are enough hospitals in Queens, given the pandemic we have just been through, and that we're seeing new viruses every day, and other things like monkeypox and other diseases?
Yeah, thank you very much, Chair Schulman. So indeed, I can comment again that New York City Health and Hospitals is a part of the healthcare system here in New York City. We do have 2 acute care facilities. They are perhaps 2 of our most robust systems. As you know, Elmhurst in particular is an incredible facility. But I cannot comment on the total number of acute care facilities in that borough, but I will ask my colleague from the Department of Health if you would like to make any comments.
Thank you, Dr. Wallach, and thank you for the question, Chair. As I mentioned in my testimony, the issue related to hospitals, including regulation, is an issue for the State Health Department. However, we're constantly not just working with our colleagues at Health and Hospitals, but also with the Greater New York Hospital Association and with private hospitals across the city during emergencies and non-emergencies, both to respond, but also to plan related to the health infrastructure.
I appreciate that. It's not sort of really answering my question, but I understand that it's a little bit tricky, so I'm going to move on. So the next thing I want to ask is, considering that asylum seekers are stretching the city's shelter system, how is that affecting hospital capacity?
Great. So I will begin, Chair, and then again I will pass it over to my colleague from the Health Department. So indeed, New York City has been the recipient of many asylum seekers coming from our southern states. Oftentimes, as you know, without advanced warning, these buses just arrive. I've been very pleased with the city's response, with the multiple agencies coming together to provide care, housing for these individuals. At H&H, per se, to your question, we have not seen a significant number of hospitalizations from these individuals who are arriving to our city. However, there is the need for basic care. There are individuals who have diabetes. The children who are coming here oftentimes don't have their school immunizations. And so we are providing access as part of our public hospital system to have a fast track for those individuals to be able to get into care, either for chronic disease management or for preventative health. Overall, however, the hospitalizations has not been significant in our system. Again, I don't know if there's anything else you'd like to add from the Health Department's perspective.
No, just thank you, Chair, for asking that really important question on this topic that we're working with our partners on every day. My colleague mentioned related to hospitalizations. I do want to just note that the Health Department is playing a key role in the city's response related to health care, providing psychological first aid and emotional support, health insurance enrollment, and importantly, with our health and hospital partners and FQHCs across the city, direct connections to primary care providers, which, as Dr. Wallach noted, is really, really important right now for everything from school immunizations to getting started on routine primary care.
Thank you. I just want to make note, as I mentioned in my opening remarks, that, COVID is still around. We have the flu season coming up. It's supposed to be a very bad flu season. What you mentioned is that there are primary care issues, and with the asylum seekers to some degree, that hasn't resulted in hospitalizations. That doesn't mean it won't in the future. And that, one of the goals that I have is to make sure that the city is prepared for that. So the next question I want to ask is, the structural issues that place financial strain on safety net hospitals remain and are already beginning to reemerge after the infusion of pandemic-related federal aid. Is there any kind of baseline standard for access to hospitals that the city will seek to maintain moving forward?
Thank you for those comments first, Chair, and for your question. I could not agree any further. Indeed, I think as we prepare for the upcoming fall and winter season, which again, we have been doing a lot of preparation for all the items that you just mentioned, because we too are very concerned about a potential for a rough flu season on top of waning COVID here in the city. There are things that are important to us. So first, the standard of care is to provide access to our primary care services within 14 days. And that is what our target is. And happy to report to the council that this is something that we have worked on considerably at H&H, and can say that our current third next available, which is our metric used for access, is 12 days for primary care services. I think a big part of this, to your point though, is to be able to expand how we provide those primary care services. It is no longer just brick and mortar. It is now telehealth services, it is virtual express care, and most importantly, it's about building out care teams. As I mentioned in the beginning of my testimony, I'm a primary care provider. And it used to be when I started in the system 25 years ago that everything fell on my shoulders to take care of my patients. And instead, more recently, we have built out care teams that include myself, a nurse, a med tech, advanced practice provider. So an entire healthcare team that is built around the patient in order to free up, if you will, the provider's schedule so that I can see more patients. So even with our existing staff, we're looking at ways to improve our capacity for the points that you made.
What's the, just out of curiosity, what is the hospital capacity now for H&H in general? Like, where are you at in terms of people being admitted and?
For our census numbers, I don't have that number. We're happy to get that back to
You
you.
can
but
get
I
it to
will
us, like, is it 90%,
But
80%?
Yeah, so I don't have the exact number, but I will tell you that we have seen, as other hospital systems in New York City have seen since the beginning of the pandemic in 2020, our hospital census has been running much higher than it was prior. And I think to your point is that many of these patients had missed care because of the pandemic, and now we're seeing the sequelae of that missed care. And so indeed, we'll get you the exact numbers, but we are seeing our hospitals busier than pre-COVID.
So has it peaked, or is it on the downswing, or is it kind of steady?
Yeah, a great question. Again, it's pretty much plateaued. We've seen kind of, in the past, we used to see seasonal peaks, to our service, and we really haven't seen that. It's really been kind of a steady census over the past 2 years.
Which I would argue shows the need for increased hospital capacity, but I'll move on. The current technical manual for environmental review in New York does not require a study of hospital or health facility capacity as part of the study of potential impacts from new development. Given the amount of new development that's going on throughout the city, including in my district, do you think that health facility capacity should be required as part of environmental review for major developments?
Yeah, so I think that is a little bit out of my realm, and I would have to defer the response to that.
Okay. 1 second. Okay, I'm going to ask about hospital support. So our city's public hospital system and other safety net hospitals serve a majority of the city's uninsured and underinsured population. Many of their sites are located in the communities hardest hit by the pandemic. The New York Times reported that these hospitals could have benefited from additional resources as they were caring for some of the patients most in need during this time. How did the administration prioritize ensuring our public hospitals and safety net hospitals received the PPE and equipment that they needed?
Yeah, thank you again for that question. And I will just say also, Chair, that in my 25 years of practice, what we have experienced over the past 3 years is completely unprecedented. Never in my wildest imagination would I have envisioned what we have been through and are going through at the current time. I will say I'm very proud of my colleagues in supply chain at New York City Health and Hospitals from the very beginning of the COVID pandemic in early 2020. They have kept our hospital system supplied, not only with medical equipment, but most importantly with the personal protective equipment for its staff, as well as for patients to be able to provide masks when they come into our facility. So for us, again, our supply chain, I don't know how they work magic, but they do, and they have been really terrific. Now I'm gonna ask my colleague, Dr. Dave Silvestri, if there's anything else you wanna add from the emergency management perspective.
Thank you, Dr. Wallach. Thank you, Council Member. Actually, all representatives from the various committees who are here today. Really important conversation. Not much to add on PPE. I would say that in general, just to remind the Council, at New York City Health and Hospitals was at obviously the leading edge of the United States response, and in some sense actually acted quicker and swifter than a lot of the guiding bodies at that time. To put in place things like, for example, airborne protections for our healthcare workers. We have, continued to see, as Dr. Wallach mentioned, robust preparedness from our supply chain colleagues, not just with regard to PPE, but also with regard to ventilators you mentioned, as well as vaccines, et cetera.
What is the census also for ICUs? Actually, now that you mention that.
Yeah, so our ICUs have found and tracked similarly to overall hospital census.
Okay.
And again, there are ebbs and flows, but overall I would say our ICU census has been increased again in comparison. to pre-pandemic. Now, I will add one comment, if I may, Chair, and that is very interesting. We're at a point now in the pandemic where the number of patients in our ICU for COVID-related illness as the primary cause of their admission is very small. In fact, last week we reviewed charts, and I think there were only 2 patients on our entire ICUs across the system that were there for primary COVID, and both of those individuals were unvaccinated. So this has been the real success in that from a COVID perspective, we've seen marked improvements in critical care.
So then it's possible that people who weren't getting preventive and primary care during that time are now the people in the ICUs. Is that corollary correct?
Yes, I mean, that could be the case. I will say, and one of the things that I joke with Dr. Silvestri all the time, we were very fortunate at New York City Health and Hospitals that pre-pandemic we had instituted our new electronic medical record system called EPIC. In my perspective, that has been a game changer, and we would not have been as successful in our response to the pandemic without it. And to your question, we use it in a way that we can do active outreach to our patients. So there was a short period of time, probably in March and April of 2020, where people were scared, quite honestly, to come to primary care. They didn't want to come into a hospital that was, quote, full of COVID. And so there were definitely people that lapsed. One of the nice things about the electronic medical record system is that we are able to have registries of patients based on their diagnosis, specifically chronic diseases like diabetes or heart disease. And we have been using that to call those patients back into care so that it's not just dependent on the individual deciding to access health care, but rather to be proactive.
Okay, I'm going to ask one more set of questions, and then I'm going to turn it over to my colleague. So during the pandemic, when the governor mandated capacity increases, how did H&H perform the infrastructure changes?
Yeah, thank you for that. I have to say, you know, I'm an outpatient provider and what I like to call a recovering hospitalist. I stopped my inpatient work 4 years ago, but I have never been more proud of my inpatient colleagues in their response to the pandemic. It was quite horrific what we were seeing in the spring of 2020, and our facilities colleagues in particular worked miracles in transforming units from med-surg into ICU level of care. We took non-traditional clinical space and made it into hospital beds. It really was incredible what they were able to do. The other big piece of this, again, selling the importance of our electronic medical record, is we operated as a system. So if one particular hospital was overrun, we were able to, within our 11 hospitals, transfer patients between sites to kind of level load. And I'm going to ask Dr. Silvestri to comment a little bit further since he and his team were the ones who actually ran that.
Yeah, I mean, it's a hugely important issue, particularly in the spring of 2020. I think, as you know, obviously, you know, there were certain pockets that were disproportionately hit during that early COVID wave. There were other parts of our system that were less hit. Even if a facility was less hit in the community immediately surrounding it, we would still open up units that were not, you know, part of the active, you know, care space prior to COVID, and really flex that. We obviously have to bring staff in to you know, care for patients in those units. To Dr. Wallach's point, we would actually transfer patients. So as a, you know, as a system with 11 acute care facilities, you know, in very disparate regions, right, we're able to really, you know, offer more capacity than we would with a single standalone site. And so I think, you know, then that was a major part of our first wave response, became a staple of our subsequent wave responses as well.
And I would use actually the analogy of building an airplane as we were flying it. And again, I am in awe of Manny and his teams. I work at Bellevue, as you know,
Yes.
and we literally, I feel like, built a new hospital within the hospital. We took space that used to be our ICUs and were decommissioned. They were being used as offices, and Manny and his team literally brought those units back to life as ICU and critical care beds, and it really was truly remarkable.
No, H&H did a lot. My last question is, for now, New York Times article recently detailed how many hospitals are redesigning their facilities for more flexible layouts that can better handle future surges from pandemics or other events. Did H&H pursue this kind of physical redesign, or are you?
Yeah, thank you, Chair. That was actually a really wonderful article in the Times. I thought it was very well written and to point. I'll defer to my colleague Manny Saez in just a moment, but what I will say is that this is something that we do at H&H. We're continuing to look forward, right, to renovate, to build us to the place. We know, unfortunately, COVID-19 is not the last pandemic, not the last outbreak that we will see in our lifetime, especially with infectious disease as our global world is becoming smaller and smaller. So I think one of the things that the Times article really brought out was the idea of having every room being a single isolation room, right, that you can readily convert. And so that is something, as we plan for future renovations, is very much on our mind. But Dr. Saez, do you want to comment anything further about our future plannings for that?
Thank you, Dr. Wallach. Yes, that was a very informative article, and we are always under consideration of what we can do with our spaces to help improve its flexibility, not only from a space perspective and be able to meet capacity, but what we can do in terms of our cooling systems, our heating systems, being able to have more real-time controls, being able to also stay green conscious and be much more energy efficient and reduce our carbon footprint for the city. So we're always working towards new innovative ways to consider our builds.
No, thank you, and I think that I speak on behalf of the council. We're here to be a assistance to you if need be. I'm going to now turn it over to Chair Narcisse for questions.
Thank you.
Thank you. You spoke eloquently about telemedicine from primary care. As a nurse, preventive care is, for me, is cost effective, and that's the way we should be going right now for what we've been through. So for telemedicine, I'm still concerned about the seniors, the homebound, without broadband. How the hospital is dealing with that populations?
Yeah, such a great question. Thank you so much, Chair Narcisse. And again, just want to thank you for your opening remarks and all of your support to the H&H system. It is greatly appreciated. You know, I have to say, as a primary care doc, your question was my initial concern in my practice back in March and April of 2020 as we pivoted literally overnight to telehealth as many patients were scared and concerned about coming to the facility. As someone who's been practicing for 25 years, my patient panel is definitely on the older end of the age range. I have a lot of patients in their 80s, a couple in their 90s, and I was really worried how I was going to provide care to these individuals, thinking they're not going to have a smartphone or they're not going to, go online. I will tell you, I've been pleasantly surprised at a couple of things. Number one, a lot of my older patients have been using technology with the help of their children. So I've been conducting telehealth visits with older individuals through the phones or a laptop computer of their adult children, sometimes their grandchildren, setting it up. And so there has been the ability to do that. Now, the other thing that New York City Health and Hospitals has done, which I'm really proud of, is they actually provide technical support for individuals. I will tell you, I am somewhat of a technical Luddite myself. I use technology because I have to, but I am not the best at it. And I felt very strongly as we were building up a telehealth program that we needed to make sure that we had customer support for our individuals. And one of the things I am most proud about is midway through the pandemic, we actually switched vendors. We changed our platform for our video visits because we were getting feedback from our patients. They were having difficulty connecting to the virtual visits that had video. And so we took that very seriously. We did an RFP, and we now have landed with a new vendor that is literally the press of a button. The technology is simple, and on top of that, what was very important to us is that our new platform has the ability to have interpreter services built in to those visits, whereas I will tell you, in March and April of 2020, I was jerry-rigging my personal cell phone where I had the interpreter, I had the patient on the computer or a telephone. Now it's seamless, it's all built in. And again, technology can help us if we know the right questions to ask and get the right equipment. So to answer your question, yes, number one, some seniors have surprised me. Now that said, there are a number of seniors who don't have adult children with them or folks who can assist them. And so for those individuals, we have made it a priority in our geriatric clinics to make sure that we have in-person visits for those older individuals. So it really is a combination, and it's up to the patient what works best for them.
Thank you. But right now, I'm trying to work on a broadband, especially around the NYCHA houses with the help of my colleagues. So, can you elaborate a little for me on the criteria you use to determine where to place the Gotham clinics or the FQHC's clinics? Because I just mentioned before, and I'm gonna keep on saying it until we get a working clinic in our community in the 46th district, which we don't have any hospitals or any healthcare centers. So can you elaborate on the specific criteria that you use to place those? Because we still have a lot of communities that the hospitals are closed and nowhere to actually go.
Yeah, thank you for that question, Chair. And I will say, we have heard you loud and clear. You have been an amazing advocate for your district and your constituents. I know that you and your office has been working closely with our team at H&H and will continue to do so. And in fact, we'll make sure that they follow up after today's hearing. Because again, we agree that every New Yorker has the right to health care, and not only the right to health care, but to high quality care. And that is what we are doing and building out with our Gotham FQHCs. And I think the latest example, is the new facility that we are moving forward with in the Rockaways in conjunction with our colleagues and support from the EDC. But again, it is a complicated process, but we are committed to working with you and others here in the city to have that move forward.
Thank you. Culturally competent care is always, as a nurse, always at the top of my mind. How are we ensuring that healthcare offered in our city is culturally competent? Can you elaborate on how we are ensuring that we are serving the unique needs of all those folks in needs? Disabled folks, limited English proficiency, limited digital literacy, which we just talked about a bit, older adults patient, all into one boat.
Yeah, so thank you for that question again, Chair. I will say one of the beauties of New York City is that we are a true melting pot. Some might say the center of the universe. And because of that, we have such a rich cultural history here in our city and amongst our patients. At H&H, as we recruit, and we are constantly looking for new talent, whether that be nurses or providers, one of the things that's really important to us is that our staff reflect the communities within which they provide care. And that is something we take very seriously. A significant number of our staff, in fact, are bilingual, which is really wonderful to be able to talk to a patient in their primary language. If they're not, of course, as I mentioned before, we have language services with over 200 languages and dialects available 24/7, very easy to use. In addition, all of our major forms, things like consent, are all translated into our top 13 languages, again, so that the individual, so the patient has that in their primary language, when they're being presented with those decisions and asked to sign forms. So it is something we take very seriously. We are very, have cultural humility, if I may, at H&H. We continue to learn from our patients, and we take their feedback, whether it's formal through a community advisory board, or even if it's at the individual level. But we are continuing to improve. All of our staff are required to go through annual in-service training on cultural humility and being able to make sure that the care we provide is of the highest quality and sensitive to the individual.
Thank you. We can ask you all kind of questions and say how you're gonna do things, but we know the bottom line is, like in my opening statement, it comes with the resources. What does H&H needs more resources to keep up with the primary care?
Yeah, thank you for that question. I would say first and foremost, the council has been incredibly supportive to H&H with specifically regard to primary care. So for that, we thank you. Right now, one of the things that we learned from the COVID-19 pandemic, if you will, with the issuance of executive orders at the state level, is that our staff has been able to operate at the top of their licenses, right? There have also been federal and state regulations that allowed us to use telemedicine, right, and get reimbursed at the same rates. And we are concerned that as we continue to remove ourselves from the pandemic, some of these benefits, if you will also go away. And so your ongoing advocacy and support specifically for telemedicine and the ability of our staff to function at the top of their license would be greatly appreciated. Now, I know you're a former nurse, and one of the things in particular, and I think you and I have spoke about this before during one of your visits to our sites, is that I believe nurses are providers. And I am very much in favor of non-patient specific orders whereby nurses on their own with their training would be able to administer immunizations, HIV tests and other things, place PPDs for tuberculosis for our patients. And I want to make sure our nurses are operating at that level. I think it also helps them become a better part of the care team. They're more engaged with their patients, and it's something that we continue to work towards.
Thank you. And I have to correct that. Once a nurse, always a nurse.
Touche.
Has the pandemic impacted access to inpatient mental health services at H&H? What about outpatient services? As of today, how many inpatient mental health beds are within H&H hospitals? Has H&H seen an increased demand for mental health services? What about services specifically for substance use?
Yeah, excellent question. Again, thank you for asking that, Chair. Indeed, I'm really proud of our system that throughout the pandemic, even in its darkest days back in 2020, we kept our doors open, specifically on our inpatient behavioral health units. And I am really proud of my colleagues for that work that they were able to do. We know oftentimes these patients who are struggling with these issues require face-to-face encounters in order to be successful with their treatment. In addition, similar to what we have done for primary care services kind of mid-pandemic, our behavioral health colleagues also implemented telehealth sessions, so whereby if patients were able to or wanted to reach out virtually, we were able to do that. Similarly, within adult primary care at Bellevue, we stood up a virtual buprenorphine clinic, getting to your question about substance use disorder, so that patients who were being treated would not have an interruption to their treatment because they physically could not come to the hospital system because COVID. Similarly, we provided, through our behavioral health services, methadone delivery to individuals, again, who traditionally would come to the facility to get their medication. We instead partnered with DOH-MH and Oasis to get that medication taken to the individual at their home. We also provided behavioral health services at the isolation hotels that were established here in New York City. We have made behavioral health a significant part of our show vans, recognizing the importance of offering those services to those individuals. And then lastly, we've kind of hardwired behavioral health into primary care. So we screen patients within primary care for depression and anxiety, for substance use disorder, and through a collaborative care program, we have behavioral social workers and psychiatrists within primary care to be able to provide those services to those individuals rather than having them go to a separate behavioral health clinic. So overall, I would say, as you know, we provide 50% of all inpatient behavioral health beds in New York State. That's a pretty significant number in our system, and I'm really proud of the work that my colleagues have done to continue to make sure their patients get access to care.
Thank you, but do you have a specific number for that? For the beds?
For the inpatient behavioral health beds?
Inpatient.
Yeah, I believe it's about 850 beds.
And you've seen an increase in substance abuse?
So we have. Again, New York City is not unlike the rest of the country, and we have seen this as a trend as part of the pandemic, where people took to alcohol or other illicit drugs during the pandemic. And again, building on the infrastructure that we had created pre-pandemic, we're in a much better position to be able to offer these services. Again, I want to highlight the fact that we offer buprenorphine within our primary care services at many of our facilities. So, yes.
Thank you. Overall, our healthcare system is shifting from inpatient services to outpatient services. H&H has previously discussed their efforts to increase capacity for outpatient mental health services. Can you please speak to this increase in capacity and provide an update on available services. How does H&H ensure that there is still enough access to inpatient care despite the shift to providing care within the community?
Yeah, so again, a really great question and a really important topic related to behavioral health. I will say that we continue to maintain our inpatient psychiatry beds, but as you alluded to, we also in tandem are continuing to grow our outpatient services, right? And so that is under a myriad of activities. That includes our clinics, that includes our partial hospitalization programs, it includes our intensive outpatient programs, or IOPs, and it also includes our assertive community treatment, or ACT teams. Again, we have built in behavioral health to our virtual express care. The theme is we are trying to meet the demand and the need of the community to provide these services where and when the patients want it. So although we maintain our inpatient behavioral health beds, we continue at the same time to expand what we're doing on the ambulatory side to provide these services, and quite honestly with the goal to try to help thwart or prevent hospitalizations.
Thank you. We talk a lot about mental health and telemedicine, telehealth. Is there any data on demographic of who's using telehealth the most?
Yeah, so that's a great question. We will have to get back to you on those details of who's actually accessing it. But again, I can tell you from my own practice and from colleagues, it has really been universally accepted, and we're seeing quite a wide range of individuals. But we will get back to you in your office with that specifics.
Okay, is there data on whether it is effective?
So again, that's a great question. Thank you, Chair. One of the things that we use to look to see how we're doing as a hospital system, and specifically on the ambulatory side of the house, are outcomes measures, right? We want to see how well our patients with diabetes are controlled, that their A1Cs are less than 8, or that their blood pressures are controlled. And what we have seen, as the rest of the country, is that early in the pandemic, we saw a decrease in some of those measures, that we've done a little bit worse. What I will tell you, thankfully, is that over the past year or so, we have seen a rebound. And in fact, our control measures are back to where they were pre-pandemic. And I think in no small part, this is a combination of not just the in-person visits, but also the ability to conduct these telehealth visits. There is a movement in medicine to do remote monitoring. Many of our patients, especially if they have high blood pressure, we have given out or prescribed home blood pressure machines. Our patients with diabetes have glucometers. And so we really are moving into a new realm of healthcare delivery where we'll have these tools to assist us to make those telehealth visits even more rich and beneficial to the individual. But I am happy to report that our measures across the board have rebounded.
Thank you. I keep coming back to telehealth because, like you said before in your opening remark, that this is not our last pandemic. We might be open for more things because we live in a global world, right? How does the lack of high-speed internet or lack of smartphone computers affect equitable access to telehealth appointments?
Yeah, again, it's a great point, and I would agree with you that even in the absence of another pandemic, which, by the way, I'd appreciate if you did not schedule another one, thank you. But even in the absence of another outbreak or pandemic, telehealth is here to stay, right? Telehealth is convenient for patients. We are learning, we are improving. It only gets better over time. And so it is part of our new healthcare delivery model. And just by way of example, during winter storms when we had some snow last year and we actually had to close clinics, in the past, those patients with appointments would have missed their appointment and we would have had to reschedule it. But instead, we now have the flexibility, instead of canceling those appointments, we wholesale switched them to virtual visits. And so the patient was still able to connect with their provider. The provider may not have made it into the clinic. They may have been at home. The patient certainly was at home, but we were able to still move forward with care. And I'm really proud of that and really appreciate and recognize the importance of telehealth to do that. Now, to your point, though, about broadband access and the ability of individuals to access virtual care, I want to remind the committee that we will meet the patient where they want to be met. So very early on, I have committed to make sure that we can conduct telehealth visits by the telephone. So if somebody does not have access to the internet or a smartphone, we will still do a visit over the telephone. And that's something very important to us from a health equity standpoint.
Thank you. My last question. I'll make a statement. Brooklyn Borough President, right, Reynoso, had invested his entire $45 million capital budget in maternal health care services at 3 different public hospitals in Brooklyn. It is a great step toward achieving maternal health equity and fighting against maternal mobility inequities, right? What are some of the things H&H is doing to close the glaring maternal health care gap?
Yeah, thank you for that question. And I would argue that some of our maternal care and morbidity that we're experiencing here in New York and through our country is the next outbreak or pandemic. And this is a really important health emergency for us. I'm very proud of my colleagues in women's health at H&H. We've done several things. There are probably 5 main interventions that we've done. The first are simulation-based programs at our simulation centers. We've created maternal medical homes modeled on the patient-centered medical homes that we've used in primary care. We've also created interval pregnancy optimization programs where we ask patients about planning so that if and when they get pregnant, they're on the right multivitamins and supplements to have a successful and healthy pregnancy. We've also created a mother-baby coordinated visit program where both the mother and the child have their follow-up visits together on the same day to ensure that they come. And then lastly, H&H has taken a strong stance against race norming, specifically in maternal health. And so you may be familiar with a calculator that people used to use about C-sections, vaginal births after C-sections, which included race as a component to that. And we have committed to eliminate that as we move forward. I think the biggest thing, however, is the first item that I mentioned, and that is our simulation. We have created incredible simulation labs where doctors and nurses can train together as a team in these high-risk scenarios, right? Whether that's worst-case scenario, cardiac arrest, hemorrhage, or other maternal emergencies. One of the things, interestingly, early on that our staff noted was that the mannequins that we were using in these simulations were all white, and they didn't reflect and look like our patients. And so they actually fed back to the vendor, and I'm happy to report because of that feedback, we now have mannequins that actually look like our actual patients. And I think that's really important, and they have now made this available, kind of nationwide. But this is something we take very seriously at H&H. And again, we have a very active Women's Health Council that continues to improve and iterate these domains that I just shared.
I thank you. I know it was not part of this, but I just had to bring it up because
it's important.
It's very important.
Absolutely.
So thank you, Chair Schulman. I appreciate your time, sir.
Thank you very much for those great questions, Chair Narcisse. I'm actually going to now turn it over to Committee Counsel.
Thank you. We will now hear testimony from the public. The first panel will be Andrew Title. Sorry, you may go, Administration. Thank you.
Thank you very much for your testimony and for your answers, and we're going to follow back up with you. Thank you so much.
Our first panel will be Andrew Title from the Greater New York Hospital Association. Please wait for the Sergeant at Arms to announce that you may begin.
Good afternoon. I'm Andrew Title. I'm the Assistant Associate Vice President at the Greater New York Hospital Association, and thank you, Chair Schulman and Chair Narcisse, for the opportunity to talk to you today. I really appreciate it. As you know, Greater New York represents every single hospital and health system in New York City, voluntary and public. Our members proudly take care of all New Yorkers, regardless of ability to pay, 24/7, 365 days a year. And in 2020, New York City hospitals, there are 62 acute care hospitals in New York City, delivered 900,000 inpatient visits. 73% of those visits were covered by Medicaid and Medicare together. There is no substitute for the highly specialized care that hospitals provide. But at the same time, hospitals are so much more than that. They've always been community providers. They run vast ambulatory care networks, and they delivered 13 million outpatient visits in 2020. This mirrors a national trend, and I know a lot of other people talking today talked about this, how we're moving to an outpatient world, and healthcare delivery is shifting to that ambulatory setting. More medical procedures can safely take place there, and we believe that this benefits patients by empowering them to seek care before they need to go to an emergency department with severe issues. Dialogue with the community is super important during this transition. New York City hospitals work with community partners, they hire a diverse, culturally competent workforce, and invest in language access for this purpose. They regularly assess community health needs and implement interventions to meet those needs through those efforts. Any discussion of healthcare today would be incomplete without addressing the ongoing COVID-19 pandemic, and that's something that people talked about today also. When the pandemic hit, New York City hospitals led the largest mobilization of healthcare resources in U.S. history. They rapidly increased bed capacity, they coordinated with government and their hospital colleagues, they mobilized staff, volunteers, and we all owe a debt of gratitude to hospitals and the heroic healthcare workers that have sacrificed so much and continue to today. I also want to address something that you brought up, Councilmember Schulman, about delayed care. Unfortunately, that was something that was somewhat inevitable during this process because of the historic nature and unprecedented nature of the pandemic, but hospitals felt the same way that you did, that it was unfortunate that certain procedures had to be delayed because of priorities, and that's why they undertook a campaign to urge people to seek care and explain the procedures that were put in place for the benefit of patients and everybody else for infection control. But we definitely hear you on that, and I just wanted to make sure I mentioned that. Hospitals learned from the pandemic, and they're preparing for future emergencies by maintaining a flexible infrastructure and coordinating with partners. Partly as a result of the pandemic, hospitals face severe challenges today, severe financial challenges. Inpatient volume is declining. Inpatient discharges decreased 8%, while outpatient visits increased 9% from 2013 to 2019. We expect this trend to continue, and from January to May of 2022, it's accelerated. Workforce shortages make it harder to find staff. Inflation is rampant. For-profit insurance companies are denying care at record levels. And perhaps most critically, and this is something that members of the committee also talked about, they incur significant losses when they treat New Yorkers with public insurance. Medicaid pays 63% of what it costs to take care of a patient. Medicare pays 80%. That is a recipe for financial disaster, and it's really the animating problem that we see in the New York City hospital world today. In view of all this, we believe that expanding community-based care while maintaining our 24/7 hospital infrastructure is the best way to improve health access for New Yorkers, and we can do that in 5 main ways. One is investing in convenient outpatient care options across the city, especially in underserved areas. Another is increasing inadequate Medicaid and Medicare rates and supporting safety net hospitals. We can close the insurance coverage gap and get everyone covered. Invest in the social determinants of health, because not everything is controlled by a hospital. And we can also invest in the workforce. Part of that is the pipeline, because there is a shortage of people that are going into healthcare for various reasons. And the other is something that my colleagues at H&H just talked about before, talking about expanding scope and ensuring that healthcare professionals can practice at the top of their license. That's something we support very strongly. Thank you for the opportunity to testify on this critical issue. I'm happy to take any questions you might have, and looking forward to working together with the council in the future.
Thank you. So one comment is that in terms of the elective surgery pieces, when Omicron became a variant in the beginning of this year, the governor, when she issued the, Governor Hochul, when she issued the executive order, excluded any cancer diagnoses from being considered elective surgery. So that's how that was how that was addressed. That's number one. But what I want to ask you was, I see where you have some suggestions on ways to achieve goals here, support Medicaid, all of that. Are you in favor of the HEAL Act, which allowed undocumented people to get, was it the HEAL Act or that allowed undocumented to get insurance? The governor, when they passed the budget, the governor, there was a push by the state legislature to allow undocumented to be able to be part of the Affordable Care Act. As you are aware, the Affordable Care Act, when it was passed, excluded them because that was the only way that it could get through Congress. The governor sort of split that a little bit and allowed people who are 65 and older to be able to do that, but are you in favor of undocumented that are below the age of 65 being able to buy insurance under the Affordable Care Act so that they could access services at your hospitals?
You know, I haven't seen the proposal of allowing them under the Affordable Care Act just because in Washington, I think it's not as viable an option, but we do support the bill in Albany, the Coverage for All bill that you may have
That's what I'm
heard
talking about. That's the coverage for all. That's,
Yeah,
I was just
so-
giving the genesis of it, yeah.
Okay, yes, we do
Okay, you
support.
do. Okay, so yeah, that wasn't included in here. That's why I asked the question. Those are the only two things for right now. Thank you.
Thank you for coming out to testify. It's very important to have folks coming out so I can ask some questions. So, nurses ratio has been a problem for H&H. How is it in private hospitals?
I think that the answer is not going to be the same at every single hospital. Staffing is something that the voluntary and public hospitals are very concerned about in New York City. We recently agreed to a law that was negotiated in Albany concerning staffing at hospitals. And what that law says, and it's going into effect soon, is basically that every single hospital needs to have a labor management committee that talks about staffing and agrees on what the best path forward is on staffing. I think that the challenges right now that we're facing on staffing are partly that there just aren't enough providers. And the other challenge that we're facing here is that we really need to include everybody here, not just RNs, although RNs are extremely important in the staffing process. And that's why we like that this law considers not just RNs, but all different kinds of healthcare professionals, including CNAs and transporters, people like that.
Thank you.
Thank you, Mr. Title. You may go. At this time, that concludes the end of in-person testimony. Unless any additional witness slips are received, we will now move to the remote testimony portion. As a reminder, once your name is called, a member of our staff will unmute you, and you may begin once the Sergeant at Arms sets the clock and cues you to start. I will now call the first remote panel. This panel will consist of Jamal Westmoreland from NYSNA, Dr. Anuj Rao of the Committee of Interns and Residents, SEIU, and Dr. Colleen Achong, Committee of Interns and Residents, SEIU as well. Thank you. You may begin when the sergeant cues you.
Starting time.
Good afternoon, Chairperson, Council members. My name is Jamal Westmoreland, and I am a registered nurse employed at Woodhull Hospital in Brooklyn, also a proud member of NYSNA. Today, I will be reading the testimony on behalf of Dr. Judith Cutchin. Good afternoon, Chairperson, Council members. My name is Dr. Judith Cutchin. I am a Vice Chair of NYSNA Board of Directors and the President of NYCHHC Mayoral Executive Council, which represents more than 9,000 RNs who work for the public health and hospital system. I am also a registered nurse employed for more than 30 years at Woodhull Hospital in Brooklyn. First, I would like to discuss the role of New York City Health and Hospitals in the New York City area in providing care for New Yorkers. The NYCHHC system accounts for almost 1/5 of the total hospital beds in New York City. We care for a disproportionate share of the uninsured on a citywide basis, receiving little or no compensation. NYCHHC operates almost half of the most advanced level 1 adult trauma and mental health hospital services within the city, services that are costly, labor, in, excuse me, labor intensive and poorly reimbursed. Many private hospitals and other private healthcare providers avoid caring for patients who are from underserved communities. NYHHC assumes a huge role on the cost of providing care for a wide range of services and populations that private sector providers increasingly dump on public sector hospitals. The COVID-19 pandemic revealed gross inequities within our healthcare system. It also revealed how short-term, profit-driven thinking by private hospital systems left New Yorkers unprepared to handle the waves of patients needing treatment and life-saving care. As we enter yet another phase of the ongoing COVID-19 pandemic and face new variant surges, and not to mention the rise of monkeypox, polio, and other diseases, nurses are demanding that hospitals focus on rebuilding a stronger, more resilient healthcare system that puts patients first, gives frontline nurses and healthcare professionals the tools needed to provide quality care for all while centering on the communities most impacted. Nurses need improved staffing to provide high quality patient-centered care, fair wages to recruit and retain nurses, along with expanding the public hospital workforce to uplift our communities with well-paying jobs and to address the needs of the communities we serve. We urge the City Council to closely monitor the financial condition of health and hospitals and increase the funding to address, I have one sentence left, and increase the funding to address healthcare inequities in the broader healthcare system while ensuring to recruit and retain nurses and healthcare professionals. Thank you so much for your time, council members, for this vital issue.
Thank you. Next, we'll have Dr. Anuj Rao. You may begin when the sergeant cues you.
Starting time.
Good afternoon. My name is Dr. Anuj Rao. I'm a third-year internal medicine resident at Bellevue and NYU and a delegate of the Committee of Interns and Residents, SEIU. Thank you to the chairs for the opportunity to testify today and for holding this very important meeting. When we asked CIR members across health and hospitals what they would like the council to understand about access to healthcare and hospital capacity, overwhelmingly, we heard stories of patients having to board for days in the ED, long wait times for primary care appointments, high nurse to patient ratios, and severe lack of staffing. One resident, when asked about hospital capacity, simply said, quote, "We are bursting at the seams." The written testimony CIR will submit will touch further on the situation at other health and hospital facilities. I wanted to paint a picture of what high patient loads and lack of staffing means on a daily basis for patients and healthcare workers at my hospital at Bellevue. So for example, Bellevue is a tertiary care center for health and hospitals. We get many transfers from the other health and hospital sites. One night, one of my colleagues got a patient. They were concerned about a bleed in the brain. He urgently needed a CAT scan, and there were no transporters available at the time. My colleague, who was a doctor managing several patients, went herself and brought the patient down for a scan, which showed a catastrophic bleed that led to an emergent surgery, which ended up saving the patient's life. If thankfully there were no other crises that doctor had to deal with, but because of staffing issues, there could have been challenges in getting the patient the care that he needed. Additionally, a lot of patients are transferred for heart catheterizations. I've seen patients wait for days and days to get this procedure as emergencies come in, as the census have been very, very high. And as you can imagine, this is extremely frustrating for patients, their families, particularly for our immigrant patients who are coming to a new country. As these two quick stories represent, we need more staffing and we need to ensure that we're paying them a living wage so that we can actually retain them. Myself and my colleagues were incredibly proud to be doctors at health and hospitals, to be able to provide care to all New Yorkers regardless of their insurance or immigration status. It's a privilege. Sadly, this means we also regularly witness patient dumping. For those of you not familiar with the term patient dumping, it's when a patient seeks care at one hospital in New York, a private nonprofit, and are deemed to their insurance status and their illness not to be profitable and are discharged to go to the closest public hospital. Very briefly, I see this very often with patients at a very vulnerable time when they're diagnosed with cancer. Many blood cancers involve being in the hospital
Time
for a long
expired.
and I
Finish.
just
Go
to
ahead.
wrap up.
No, go ahead. Finish. I'm sorry.
Thank you. Just a few other seconds. When patients are vulnerable and diagnosed with these leukemias or lymphomas, they're discharged from these hospitals and told to go to Bellevue to receive their care. So as the council addresses access to care and capacity for our hospitals, I urge you to look beyond just census numbers and examine this through the lens of our for-profit sick care system that can also dump patients like the ones I just told you about. Thank you very much for this time and the privilege of speaking. Thank you.
Thank you. I have a couple of questions for you, Dr. Rao. Thank you very much for your testimony. Do you think that there's enough hospital capacity for future surges or pandemics or any other crises, just in general?
Again, just in my personal experience, I think at this time, during that initial surge in March of 2020, everything was bursting at the seams. And over the past year, as the folks previously testified, the census, then again, I can't give you hard numbers, but just from witnessing, they've been over 100%, and we definitely need more staffing and more beds. And it's been like this for over a year now. As the pandemic still goes on today, we're not seeing as many deaths from COVID, but from other holes in our social safety net, from staffing at nursing homes, patients not getting their care at clinic and putting things off. All these patients end up at one place, at one site that cannot turn them away, which is a hospital. And I want to shout out to all the providers doing an incredible job. But with the last 2 years, it's been extremely taxing, and we need support to continue to provide a high level of care that all these patients deserve.
What about, are you familiar at all with inpatient capacity for psychiatric patients?
Unfortunately, I'm not.
Okay.
Yeah.
All right, thank you very much. I really appreciate, again, your testimony.
Thank you, Doctor. We'll now move to Dr. Colleen Achung from Committee of Interns and Residents. Please start when the sergeant cues you.
Starting time.
Good day, all. My name is Dr. Colleen Achung. I'm a second-year internal medicine resident at One Brooklyn Health and a regional VP for the Committee of Interns and Residents, SEIU. Thank you to the chairs for the opportunity to testify today and for holding this important hearing. Much of the discussion of access to hospital care and hospital capacity centers around census numbers. I would like to use this time to give you a picture of what it actually means and when we have high census numbers in the hospital. For example, in January, an unexpected COVID and monkeypox surge occurred in New York City, which is different from the surge that occurred in February with the Omicron surge. These patients, many of which stayed in the ED and had to be managed. Not only as a physician, I had to manage patients on the 4th floor where I was the primary doctor there, as well as several patients in the ED, either be it for monkeypox or for COVID. Some of the monkeypox patients that I was seeing were just came into New York City that were sent from Texas and were living in the shelter not so far off from our hospital facility. This high patient numbers are one aspect that impacts how we deliver care. The other is our resources and staffing. If you ask any resident or physician at a Safety Net hospital in New York, they will tell you that their hospital needs more nurses and more ancillary staff, such as transporters, phlebotomists, EKG technician, patient care aides. They're direly needed. Many of the times, patients will remain in the ED and unable to get a bed until to the point that they would have to be discharged directly from the ED. This impacts patient care in the direct way that the doctor is unable to see the patient as many times as would be preferable in a patient-centered care model. Crowding and a large surge in census will impact the way that we treat patients and the type of care that they receive. I'm incredibly proud to be from the community that I serve, and it's not a secret that there are so many members of people in this community that are in need of work. They need good union jobs, and the need in our hospitals for more staff is real. We need our hospitals to hire more nurses as well as ancillary staff. Finally, I want to draw your attention to the fact that all the issues that patients face and have raised, that I'm sure others will raise or have raised in the hearing, are only exacerbated and harder to navigate if they're non-English speakers. Many of the patients I would point to are some of which that were brought to New York from Texas and are difficult, some of which I've treated personally. And they not only are they diagnosed with monkeypox, sometimes they're diagnosed with a newly diagnosed HIV or sexually transmitted disease diagnosis. They should have not only proper care, but also be able to understand what is going on with their health. Thank you for this opportunity to testify today and for taking this serious issue we as residents face every day, as we do all we can to provide the best care possible for our patients.
Thank you very much.
Thank you for your services, for caring for the most needed the services in our communities. So if you have to summarize in one sentence, what you think can be done right now, especially for the folks that you're serving right now? If you have one thing you can ask from us. Is she here?
I was muted, sorry.
Okay.
So I would really ask direly of hiring more ancillary staff. More than anything else, hiring the ancillary staff is very important because it impairs the type of care that I provide to patients. Let me give a basic example. A patient comes in with chest pain or shortness of breath, and they need an echo, and you only have one echo technician in the hospital. Now, patients will wait probably 10 days until they can get this test because they don't have that ancillary staff. If a transporter needs to be called, many times I have advocated for my patient, so I would push the patient myself to the surgical ward or to the CT scan or to the MRI because I know that this patient does not need to stay in the hospital. It predisposes them to more infections, to more risk. So I want my patient to have the best care that they are treated and then they're properly discharged so that they can be further managed as an outpatient setting at home. But if we don't have the staffing, those things cannot be done.
Thank you so much.
Thank you, Doctor. I'm going to call our next panel. It will be Judy Wessler from the CPHS Board, Medha Ghosh from Coalition for Asian American Children and Families, Amanda Dunker from the Community Service Society of New York, and Taras Shabaniak from the Mayor's New York City. Yes, that's the last one. Thank you. Judy Wessler, you may start when the sergeant cues you.
Starting time.
Thank you for this opportunity. I'm sorry I don't have a written statement at this point, but there are just 2 points that I wanted to make. And I have to say that Dr. Rao's point about patients being dumped, I would hope would be something that the council would be interested in following up as something very key and should not be happening. The second thing I want to say is there seems to be a lot of ambulatory care in the city, but at least in Manhattan, one of the things that's happening is that the academic medical centers in particular are opening ambulatory care sites, but they're not taking, they're opening them as, I guess, private practice, and they're therefore not obligated to take Medicaid or uninsured patients. And so it looks like there's a lot of services for those patients, but some of it is I'm looking for a word, I guess, illusory is the best term I can. The other thing I wanted to say is that we are part of a coalition effort that is having discussions with the state health department and would certainly, and we'd be happy to talk to you more about this. We would be happy about how to better distribute the indigent care pool funds, which have been misallocated or disallocated or whatever word works, for one. But in addition to that, there is $800 million in the state budget for this year for safety net hospitals. So the way that that gets defined is very critical. And that's something that we hope to be working on with the state health department. It could, again, would really appreciate the council's support. There is a definition in law that some of us fought very hard for a number of years. The former governor would veto it, and then we'd have to go back again. It took 4 years, but there is a definition, and those funds should be allocated to actual safety net hospitals, which of course includes all of the public hospitals and some of the voluntary hospitals as well that actually take care of people a lot in the same way. I'm sorry, I'll finish. A lot in the same way as the public hospitals do. And that would bring more resources into the safety net hospitals so they could do a better job. I had a friend who said, if you don't allow me to have the budget that I need, I'm not going to be able to do the job that I'm supposed to do. So we need to work on the budget. And thank you for this opportunity.
Thank you. Medha Ghosh, you may begin when the sergeant cues you.
Starting time.
Good afternoon. My name is Medha Ghosh, and I'm the Health Policy Coordinator at CACF, the Coalition for Asian American Children and Families. Thank you very much, Chair Shulman, Narcisse, and Salamanca for holding this hearing and providing this opportunity to testify. Founded in 1986, CACF is the nation's only pan-Asian children and families advocacy organization and leads the fight for improved and equitable policies, systems, funding, and services to support those in need. Nearly 19 million people reside in the New York City metropolitan area, and over 800 different languages are spoken. Because of New York's linguistic diversity, it is incredibly important to ensure language access. Language barriers are a huge obstacle faced by many folks in immigrant communities, and especially in the AAPI community. In New York City, the AAPI community has the highest rate of linguistic isolation of any group, as 46% have limited English proficiency, or as I'll say LEP from here on, meaning that they speak English less than very well, according to a recent report from the New York State Department of Health and Mental Hygiene. Moreover, more than 2 in 3 Asian seniors in NYC are LEP, and approximately 49% of all immigrants in NYC are LEP. Language barriers can prevent folks from accessing vital services like healthcare. Despite there being 76 language access policies targeting healthcare settings in New York, we have found that many LEP patients still report facing difficulties like being
Can you slow down a little?
Sorry, my apologies. Let me start from this paragraph. Language barriers can prevent folks from accessing vital services like healthcare. Despite there being 76 language access policies targeting healthcare settings in New York, we have found that many LEP patients still report facing difficulties like being unable to find an interpreter that speaks their dialect or being unable to fill out paperwork because a translated version in their language does not exist. A lack of linguistically accessible services in healthcare settings can have grave consequences. 50% of adverse events that occur to LEP patients in U.S. hospitals were likely the result of communication errors, and nearly half of these events involve some form of physical harm. In response to this, CACF's campaign, Lost in Translation, aims to ensure that New Yorkers have equitable access to linguistically and culturally responsive healthcare services. Over the past 2 years, CACF conducted quantitative and qualitative research to identify the key barriers that LEP New Yorkers face in healthcare settings and identify corresponding recommendations. Our major recommendations for the LEP New Yorker community, which includes many of the members of the API community, are as follows. Demand healthcare institutions collect more data on translation interpretation services and service utilization, increase the number of languages for translated signage and forms, and ensure accuracy of translations by engaging community partners in a language review. Ensuring accountability for language access complaints, and create more opportunities to increase the number of practitioners who speak the languages of the communities they serve. Overall, we see a need for more intentional collaboration between the city and community-based organizations to better identify language access gaps in our communities and to find solutions that will have a direct positive impact on the well-being of our communities. Thank you very much for your time.
Thank you. We'll next have Amanda Dunker. You may start when the sergeant cues you.
Starting time.
Thank you. My name is Amanda Dunker. I'm Health Policy Director at the Community Service Society of New York, which has been serving low-income New Yorkers for over 175 years. One of the things we do is our suite of health programs, which help over 130,000 people a year enroll in health insurance and then use it to actually access care. We've been doing a lot of research into medical debt, and fear of medical debt stops people from accessing care when they need it. The burden of medical debt falls disproportionately on people of color. In a series of reports on financial consequences for hospital patients, we found tens of thousands of lawsuits, as well as thousands of instances where liens were placed on patients' homes and their wages were garnished. We've also found that hospital lawsuits are disproportionately filed against patients who live in low-income communities or communities of color. So communities where the majority of people are people of color or just disproportionately people of color. A lot of New York's hospitals have revisited some of those aggressive collection practices in the past few years, but we think that there are a few policy changes that should also be made to create more consistency and fairness for patients across the board. All of New York's hospitals are nonprofit charities and are required by law to offer financial assistance to low and moderate income patients in the form of discounted prices. Compliance with this law allows hospitals to receive support from the state's indigent care pool, which Judy mentioned earlier, which distributes $1.1 billion annually. CSS has found that a lot of the patients who are sued are likely eligible for financial assistance but did not receive it. And there are significant differences in the amount of financial assistance provided by individual hospitals in the city and across the state, which are not reflected in how the indigent care pool is distributed. Some of the solutions have to be implemented at the state level. We think there are two bills in particular that the City Council could consider expressing support for. One is S5954, which Judy mentioned, which would reallocate the state's indigent care pool funding to prioritize this category enhanced safety net hospitals. Another is S7625, which would improve how financial assistance, the application process works. So it would provide a consistent process at all hospitals and would increase the eligibility to 600% of the federal poverty level, which is consistent with the levels at which the Affordable Care Act provides assistance to patients. The city should also consider participating in the rulemaking process for a state law passed last year related to the Certificate of Need process. The Health Equity Assessment Act means hospitals participating in the Certificate of Need process have to submit health equity assessments to the state that explain how the proposed change in services would affect underserved populations. The city should consider weighing in as the law is being implemented to make sure that those assessments are conducted independently and that they result in meaningful community engagement in health planning decisions. Finally, at the
Time
city
expired.
level, I'll wrap up. At the city level, a more proactive role could be adopted in ensuring that all patients are able to access hospital financial assistance. The city does extend preferential tax treatment towards hospitals due to their nonprofit status. And given the value of this preferential tax treatment and the city's investment in health and hospitals, we think it has an interest in ensuring that all hospitals provide their fair share of healthcare to the city's low-income and minority populations, and that includes the private hospitals as well. So we think maybe the city could consider even just investigating how many patients are successfully able to get financial assistance and which hospitals are providing the most financial assistance. Thank you.
Thank you. We'll now call Taras Zebniak. Sorry for the pronunciation. You may begin when the sergeant cues you.
Starting time.
Hi, good afternoon, chairpersons and council members. Thank you for your time. My name is Taras Zebniak. I'm here in my individual capacity as a concerned citizen. My testimony relates to the mayor's city worker COVID injection mandates. As the committee overseeing health, you have a key function managing us through crises like COVID while preserving our human rights and holding the mayor and his team accountable for their violations. I would start by noting that arbitrarily firing people due to ineffective and medically dangerous COVID injection mandates throws those people into despair. It destabilizes them and their families. It worsens their physical and mental health and that of their families, and it taxes our healthcare system in the city. With that said, I want to get 5 key points on the record today. Point number 1, yesterday, President Joe Biden declared the pandemic is over. So why hasn't the mayor rescinded the worker mandate? We need the council to act and fix this. Point number 2, the New York City worker mandate remains in effect and continues to destroy lives. There seems to be some misunderstanding about whether the mandate remains in place. Both the public and private worker mandates remain in place. New Yorkers still cannot work, and people are still getting fired. Teachers, nurses, sanitation, police, and firefighters, the people who run into burning buildings for us, cannot feed their families under Mayor Adams. The prior worker mandate also remains in effect. The mayor said he is not enforcing that mandate, but it remains on the books, and employers are still firing their workers because of it. Goldman Sachs recently lifted their COVID mandates worldwide, except for New York City and Lima, Peru. Those 2 cities still have private worker mandates. Just weeks ago, my personal friend here in New York had to inject herself against her voluntary consent on penalty of being fired. Point number 3, democracy can only function with proper checks and balances. The mayor has abused his emergency powers since he moved into Gracie Mansion. He has declared an unending COVID emergency against all facts, reality, and common sense, betrayed by his own behavior, going to crowded events every day without any masks or distancing. I personally heard his administration refuse to answer simple questions about the COVID mandates in this chamber on September 9th. We need the council to provide checks and balances and enact laws that prevent the mayor's abuses of power. Point number 4, this is a heavy point, but we must recognize that the mayor's worker COVID mandates violate the Nuremberg Code. For those unfamiliar, the Nuremberg Code is a set of ethical guidelines for medical experimentation on human subjects to ensure that Nazi atrocities never happened again. I'll read the code for you. The voluntary consent of the human subject is absolutely essential. This means that the person involved should be so situated to exercise free power of choice without the intervention of any element of force, fraud, deceit, duress, overreaching, or other coercion. An ultimatum that you're fired if you don't take an unwanted COVID injection is coercion and duress. mRNA injections are a new technology with no long-term safety data and therefore by definition are experimental. A recent study published in Vaccine Journal found a 1 in 800 serious adverse event rate. For a city like New York, that means 10,475 severe injuries or deaths. That is a tragedy. My final point, we the people are frustrated and angry. Our government appears to be intentionally hurting us and violating us. We feel as though the mayor and the council are not listening to us. We feel helpless, hopeless, and unheard. I would hope that this council recognizes and pushes back against the mayor's usurpation of your power and against his ongoing human rights violations against New Yorkers. Please pass a resolution recognizing the abuses of his power. Please pass a law that limits the use and duration of emergency powers. Please declare the pandemic over, agree with President Biden, and demand an end to the mandates. Please let all New Yorkers get back to work. Thank you very much.
Thank you. If there is anyone else present in the room or on Zoom that hasn't had an opportunity to testify, they can raise their hand now. Okay. So seeing no one else, I would like to note that written testimony, which will be reviewed in full by committee staff, may be submitted to the record up to 72 hours after the close of this hearing by emailing it to testimony@council.newyorkcity.gov. Again, that's testimony@council.newyorkcity.gov. Chair Schulman, we have concluded public testimony for this hearing.
Thank you. I want to thank everyone for testifying today and answering questions. This is an important topic. We'll be pursuing it further in the weeks and months to come. And with that, I close today's hearing.